This swollen face started with a single tooth, and within days, the infection had spread across half his face. Now we have serious swelling that is already spreading to the orbit, and if left unchecked, it can get even worse. Today, we are removing a difficult maxillary molar and draining an infection to stop it from spreading. I'm Dr. Tom Bolton, and this is the open reduction. This tooth, the right maxillary first molar, has a failing crown, and it's hiding some serious problems underneath. The tooth has cracked into the root, and the patient is unaware because of the previous root canal he had. Infections like this can hide for a long time, but they can eventually break through the jawbone and cause serious problems, like what's happening here. Our goal today is to remove the source of the infection by extracting this broken tooth. And later, you'll see why this infection needed surgical drainage, not just an extraction. The first step is local anesthesia. This can be difficult in an infected site, so I use a generous amount to make sure the patient doesn't feel any pain. I already suspect this is going to be difficult. This is a maxillary first molar, the biggest tooth in the mouth. Whereas most human teeth have 1 or 2 roots, this tooth has 3 roots that go off in different directions. This tooth has a failing crown and there is decay underneath. I put in a throat pack and the crown pops off not long after the forceps touches it. This is actually a good thing, as the crown is only acting as an interference at this point. Now that the crown is off, I have access to the rest of this tooth. The next step is critical. I am going to section the tooth where I know the roots to be, and then remove each root individually. I'm sectioning the tooth because preserving bone is going to matter later. I use a round burr to section the tooth, and I go deep to get through to the furcation. However, I don't want to go too deep and drill right into the sinus, so it's a fine balance. I also create a small purchase point along the mesial aspect of the root so that I don't damage the adjacent crown when I'm elevating. This tooth is root canal treated, which means it hasn't had a nerve or a blood supply for years. This makes teeth extremely dry and brittle, and root canal treated teeth often break into many pieces. See this large bump right here? This isn't swelling from the infection. This is rock-hard bone overgrowth called exostoses. This patient's jawbone has gradually thickened with time, probably due to grinding. His bone is twice as thick as the average maxilla, and this is dense cortical bone. Early in training, many clinicians don't realize that exostoses are a sign of a difficult extraction. This tooth is in bone that has the consistency of cement. As I gently elevate the roots, each one breaks deeper in the socket. Here is where things get difficult. I know each of these roots is one wrong move away from falling into the sinus, so it's vital to get this next step correct. Technique matters so much more than force. Remember, this tooth has a large shadow at the base of the root, which means chronic infection. Not only is this tooth large and fragile, it is sitting in an infected and inflamed socket, which means increased bleeding and surgical difficulty. Just to add another challenge, this tooth and infection are immediately adjacent to the maxillary sinus. This infection may very well already be pouring into the maxillary sinus. There could easily be a hole from the mouth into the sinus when this tooth is removed. It is very easy for a tooth root to fall into the maxillary sinus while extracting it, which leads to a different set of problems and potentially a much bigger surgery. I remove as little bone as possible to get a purchase point for each root tip. This is where things can go wrong. I'm trying to prevent these small roots from falling into the maxillary sinus. As I elevate the roots, I'm watching for any movement in the wrong direction towards the sinus. I'm able to successfully remove each root tip. Sometimes these infections drain through the extraction socket, but this one is not. At this point, it's clear extraction alone won't solve this problem. I make an incision in the vestibule of the right maxilla, and immediately blood comes rushing out. Swelling like this means an abscess has already formed or the infection is still growing and spreading. The earlier stage of an infection is called cellulitis, and that's what's happening here. I'm so happy I took care of this when I did, because this was only going to get worse. Even though there is no abscess to drain, it is still helpful to open this area, explore, irrigate, and place a surgical drain. Here is the packing in place, which I will remove 3 days later. This case is a reminder of how fast tooth infections can escalate and why early intervention is so important. Within just a couple days, the swelling began to resolve and he's now doing great. I'm Dr. Tom Bolton. Thanks for watching the Open Reduction Oral Surgery.